Our final speaker before lunch is Dominika Lisiecka.
Good afternoon, everyone. My name is Dominika Lisiecka, and thank you so much to the organizing committee for letting me to speak to you today. So, just to give you a little bit of background, because my name clearly is not Irish, and I'm speaking to you today from Ireland. 15 years ago, this is me, I did a master's degree in speech and language therapy in Warsaw, in Poland, and I decided to go to Ireland for a holiday. And I'm still in Ireland. It doesn't feel like a holiday anymore. And 2003 was a very significant year for me because that was the time when I started working and became really interested in neurological dysphagia. And a few years later, I worked in the hospital in Tralee in County Kerry in Ireland, looking after people with ALS. Last year only, I completed this research project at the University College Cork in Ireland, and I also started lecturing in adult neurology in University of Limerick, all in Ireland. And my office is in this fancy building with the curved roof there. Okay, so why do I want to talk about perception of food? And what do we know about it already? We know that perception of food influence the way we eat, the way we shop for food, the way we cook and dine. And it does dictate our schedule of meals in terms of what we eat, in what quantities and when. And there is lots of factors that impact on our perception of food. Also, historically, there has been a shift in our eating habits, and we rely much more on convenience food. We dine out a bit more than, let's say, our grandparents did in the past. And it's been recognized that the food choices are dictated now mainly by social norms and associated with our emotions and feelings. So even the fact who are we dining with may impact on our food choice. Obviously, there are other factors like our tradition, culture, religion. So these are just different pictures of food from Asia that, may or may not look appealing to all of us. We also use our cognitive knowledge around food when making food choices, such as some food that is maybe nice but not so healthy, and other food that is considered a little bit more healthy. Okay, so why do we eat what we eat? It's been recognized that food choice is a complex human behavior influenced by a lot of factors, be it biological, genetic factors, and obviously cultural and social issues. It's not only based on our biological needs. We don't necessarily have to be hungry to eat, and we don't always eat food that we would like or prefer to eat. And some of the influences in food choice might be unconscious. When I think about this, I remember a quote from Professor Thomas Bach from the ALS Symposium in Dublin 2 years ago, when he said that there is two groups of people. Some people live to eat, and other people eat to live. So the role of food in our life is very, very interesting. So the questions that I started to have was, can dysphagia influence our perception of food? Can ALS as a disease, as an illness, influence perception of food? And can caring for someone with ALS influence perception of food, personal perception of food? And according to my study, the answer to all these questions is positive. Why is it important to even think about perception of food in ALS? Well, I think it is very important because we know that nutrition has been recognized as a very important prognostic factor in ALS. We know that food routines can impact on social and family life. And also, what my research was suggesting is that perception of food can actually influence the compliance with any food-related recommendation that is being made to the person with ALS. So what I mean here is when we, as speech therapists, perhaps recommend someone to alter the consistency of food or liquid, or indeed to start non-oral feeding. So just to give you the context of the study was completed in southwest of Ireland, and I recruited 10 people with ALS and 10 caregivers of the people with ALS, and they were not necessarily related to each other. In total, there were 61 interviews, so I spoke to every person more than once, and I also included observations of mealtime. And data collection took 9 months. The methodology was interpretive phenomenological analysis, IPA. All you have to know from this that it was a qualitative study, and in terms of data analysis, every person was analyzed individually in depth before I conducted cross-case analysis of group of people with ALS and the group of caregivers. And my main interest when I was designing the study and conducting the study early on was to investigate the experience of dysphagia in ALS. But because life is full of surprises, that was not necessarily the interest of the people I was talking to. And a lot of the time, they changed the topic of conversation and spoke about other issues that were more important to them at the time of the interview. For example, fear of losing communication skills or their voice. And that was really interesting because it emerged that people were, so all of people with ALS in my study had dysphagia. They were all receiving speech and language therapy services for dysphagia. They were admitting modification to their diet. But despite of all these factors, some of them, actually half of them, denied having dysphagia at some point of the interviews. And what emerged was that they were so living in the current moment that if dysphagia was perceived as an issue on the day of the interview, they wanted to talk about it. But if they're not perceived dysphagia as an issue at that moment, they almost detach from it and prefer to talk about something else. So a little bit more about people with ALS. The mean age was 67, which is, I suppose, in line with the peak incidence in Ireland. A perfect gender balance, 5 male, 5 female. The majority were married and retired. And the mean time since diagnosis was 20 months. All of them had cognition either normal or within normal limits as tested by ECAS. And half of the sample had a gastrostomy in situ. 80% were though eating oral diet, and 20%, so just 2 people were on a non-oral diet exclusively. In relation to the caregivers, the sample was a bit younger, so 57.5, 8 female and 2 male. All of them were married. 60% retained full-time employment on top of looking after someone with ALS. And 60% were spouses and 40 were children of someone with ALS. And the mean time since diagnosis, just over 2 years. So in terms of the results, so let's talk about people with ALS first in relation to the food perception. What people were reporting, it emerged that the perception of food for the group of people with ALS started to change as ALS progressed and as their dysphagia became more severe. So as ALS progressed, they were reporting having a lower appetite and decreased stamina, and they weren't necessarily feeling like eating a lot. Also because of dysphagia, their diet became very repetitive, and some of them decide to eat exactly the same meals every day. Also, because of the swallowing problems, they were not able to eat the food that they would like to eat all the time. A couple of quotes for my participants. I eat the same meals every day. I get full quicker, and maybe tiredness is a factor. I love soda breath, but had to recently change. Swallow is a bit off-putting. I had 2 cups of tea and I didn't enjoy it. So what happened with time is that people were reporting they're actually not enjoying food as much as they used to before. And all of them actually, just to clarify, were, I suppose, were reporting their love for food before they became sick with ALS and then dysphagia. So as the dysphagia progressed and their diet had to change, they almost began to detach from food. It was not associated with any source of pleasure anymore. And I remember one situation when one participant was actually talking about not enjoying his cup of tea anymore. And the whole interview was, I suppose, around expressing lack of enjoyment in food. And the next day he sent me a text, I've decided to go for a peg feeding. So that kind of process of the food was not any source of, I suppose, enjoyment. And then it was that, I suppose, easier for him to decide to go and have gastrostomy, although it had been recommended months before. In terms of caregivers, I suppose the perception of food, the emotional impact of food was really very, very strong at different levels. Some caregivers reported feeling guilty when they were eating in front of a person with ALS who was not able to eat anymore, or not able to eat what she would like to eat or he would like to eat. Also, the food preparation at home when they were cooking, that activity itself was perceived as potentially upsetting for a person with ALS. Got to the stage that one lady said to me that when they were watching television and when there was any ad including food, she had to switch off the television because she felt that would upset the person with ALS. The caregivers starting to shop for food in a different way, and they're starting cooking and preparing food in a different way for two reasons. Reason one was obviously dysphagia, but reason two was, I suppose, their focus on maintaining calories for a person with ALS. So I now buy double cream on very regular basis. When I'm cooking, I have to have the door closed. So that's the emotional impact of preparing food there at home. Literally everything gets chopped down. There is going to be no more T-bone steaks. Nobody can eat in front of her. I feel bad when I'm eating. And I suppose on the emotional side as well, the eating routines were perceived as very important by the caregivers. And there was one gentleman his wife was not eating anymore. She was exclusively on tube feeding. But he was telling me that he still brings toast to her bed in the morning, and she cannot eat the toast anymore. But she gives them to their dog because the dog expects that. And that is a really heart-melting moment when you realize how those kind of routines that people develop are important, and maintaining them can be very important for people living with ALS as well. There were some similarities between the perception of food in both groups. Both groups believe that food influences the course of ALS, and that they can actually, maybe to the point even control the disease a little bit better, or control it at all by food. I must have full breakfast, lunch and dinner, said one of the men with ALS, and then he said that he gets really anxious and angry if his schedule of meal is not maintained. Food is really important for the muscles. Before I didn't care, another lady with ALS. This is the caregiver now. On day one, the first thing one of the motor neuron nurses said, just keep the weight on. I think about calories all the time. So yes, there was a similarity. Both groups believe that food is really important to maintain the muscles. But that perception emerged in the caregiver group very early on at the time of diagnosis. And it seemed to develop with people with ALS later. Fear of choking emerged strongly in both groups. One lady with ALS reported, you had the most ferocious feelings of panic that I was going to choke. And then the caregiver, he's putting a load of stuff on the fork. I'm there going, please don't choke on that. And because of that fear of choking that was actually ongoing, food was perceived as risk. For safety, I stopped eating, said one lady when we're talking about, she was again on a different lady on a purely non-oral diet. I have to be careful about bite size. You were uneasy all the time when she was eating because you'd be kind of watching, was it going down or was it getting stuck? The food is on my mind. I don't want him to choke. So in relation to similarities again between the two groups, the fear of choking emerged very early on in the caregiver group, later in the people with ALS. And in terms of conclusions, it appears that ALS can influence personal perception of food. this perception can be further influenced by the presence of dysphagia. So what I mean in the point one is that the diagnosis itself, when people hear that they're going to perhaps do better if they maintain the weight. So the weight is really important, the nutritional supplements are important, the food rich in calories is very important. That changes the perception of food straight away, especially in the caregivers group. Because all of a sudden they start shopping differently, they start cooking different meals at home. And this perception is further influenced by progressive dysphagia, when the person is becoming perhaps not able to maintain the same diet as before, or to maintain oral intake at all. Food was compared to a fuel and considered as medication for ALS by some participants. And food can be associated with strong emotions in ALS, especially when oral intake is poor. It was very hard for the caregivers when they're observing the person with MND or ALS not being able to eat the same quantities of food, because they were so aware that they believe that can decrease survival. And also the fear of choking emerged really strongly in both groups, and I think that should be addressed. In terms of implications for practice, I think it's quite important to ask about personal perception of food when delivering services around food or dysphagia to people with ALS. You may get much more information than just asking about the swallow. Do you have any difficulties in swallowing? That may not give you a lot of insight into what's really happening. But when you talk about perception of food, and when you, for example, with a person with ALS, and when they report that the food is not perhaps as enjoyable as before, that might be a very good moment for them to talk about or be introduced to normal feeding. Perception of food may impact on the level of compliance with food-related recommendations, and fear of choking has multiple consequences for people living with ALS and should be addressed. I would like to acknowledge all participants who took part in this study, Health Research Board who funded the study, my supervisors for the project, Dr. Helen Kelly and Professor Jackson from UCC, my official collaborators for this fellowship, Professor Orla Hardiman, Dr. Helena Moore, and the Irish MND Association, and my mentor at UL, Dr. Arlene McCurtain. It wouldn't be possible without the help of all these people to conduct the study. Thank you very much, and I would like to answer any questions if there are any. Thank you.
Are there any questions?
My name's Dewi from Cardiff and Vale, one of the dietitians. It's interesting with the perception of food. I wonder if you had any queries regarding liquidized feed or blenderized diets, because something that's emerging in Cardiff at the moment is that people trying to take on the diet aspect and blending food for tube use. But I wonder if that had been approached in your study.
Okay, I'm not sure I've heard the end of it. So you're asking about any data around blended diet, is that?
Yeah, more feedback from patients and carers in an effort to take more control over the diet.
Okay, so the general feedback from people with ALS was that they were really trying to manage dysphagia alone for as long as they could, and they preferred to self-manage rather than looking for professional help. And part of the self-management was that what they were reporting to me, that they naturally started to alter the diet consistency in order to make it easier to swallow. So they were cooking food for a longer time or chopping in smaller pieces using extra sauces. If that was, I suppose, perceived as a strategy self-developed to manage dysphagia, they were applying it and they were happy with it. If that came professionally recommended, it was not necessarily perceived as something that they were willing to do. And I think that was associated with their perception of food and how important, how attached to particular food they felt in any given moment. Yeah, so the feedback, I suppose, that I got in terms of changes in the diet consistency was a bit better in comparison to changes in fluids consistency. So any thickened liquids, recommendation to thickened liquids were usually perceived as very difficult to follow and very, very unpleasant. Thank you.
Thank you.
Right. I think it'd be good if you would find the speakers at lunchtime and perhaps ask them any further questions.
Thank you.
Since we are running a bit behind.